Hi, I'm Steve Keene, CEO at the North Carolina Medical Society.
And I'm Mike Utecht. I am the past president of the North Carolina Medical Society and the current chief medical director at Carolina Complete Health Network.
As we approach the merger of Carolina Complete Health and WellCare of North Carolina, we wanted to discuss some of the important things that physicians can know and understand about this health plan and the medical society and the medical community's role in the formation and growth of the health plan over time. For the first time in the North Carolina Medicaid history, every Medicaid enrollee will have an opportunity to enroll and receive health coverage through a provider-led Medicaid health plan, a provider-led entity. Mike fills an important role for the health plan as Chief Medical Director for Carolina Complete Health Network, the company that is owned together by the North Carolina Medical Society and the federally qualified health centers in their association.
I mean, I think one thing I'd like to do is spend a couple of minutes just talking about how we even got here, right? Because I think it's important to know what is this? Like, how did we come to be in the first place? When this idea came up, we were as a state, the state was running Medicaid and they were sort of done with it, right? State said, we're done with this, we're not gonna do this anymore. We're gonna move to Medicaid managed care. And everyone was like, oh my God, I mean, I'm a doctor, right? And I'm like, you guys in this audience saying, that's horrible. It's not a good plan. Other states have not a good idea. It's not really shown to be effective, and it wasn't really helping the people that need to be helped, the most vulnerable people in the state. Didn't matter. The state came around and said, that's it, we're gonna do it, and you guys are just gonna like it, and we're gonna throw it out there to bid. And so as a board of physicians, it came to us an opportunity to do something that never has been done anywhere before. And that was, rather than being on the outside looking in, what if we're on the inside? What if physicians can actually be in a situation in a company where you have a say? You don't have a say at the end of the policy, but you have to say at the beginning of the policy. That you have a say in how we're going to treat patients. How is my administrative burden going to be handled? How can we be the most effective and actually have a say in how we're going to direct care to our patients in North Carolina? And this has never been done anywhere. It was like this is sorcery. Like who does this, right? But we were going to do it, and it was a really big lift. And that's how we got to where we are over time to where we are today. And so, as part of my role and as part of what we do at the Carolina Complete Health Network, is we are that physician voice, right? We work with all the policies, even if they come from a corporate level. We look through policies and we reach out to our local providers in North Carolina who provide care to our Medicaid patients and say, what do you think about this policy? Does this policy make sense? If it doesn't make sense, how do we need to change it? How do we make this specific for North Carolina? So we were very passionate about making sure that the care that is being delivered here is being driven by physicians and who always have a voice. This is like near and dear to me because this is my career. This is what I do. I'm just a simple emergency medicine guy. That was my background for over 30 years. As we say in emergency medicine, this is where bad policy reveals itself, because everything that's bad about medicine ends up in the emergency department because it is always the de facto safety net. I think we had a president one time that said, why do we have to worry about everyone having health care? They're emergency departments. And that's absolutely not what we want to have happen. That's where bad policy ends up. People not getting care, people not having access to care, people not getting timely care. Substance use disorder, mental health disorder, bad behavioral health system, all those things have emergency medicine. So I think that having that voice and letting people know, like, look, that looks great until when the rubber meets the road, and that doesn't work, and it ends up over here, and then someone else has to solve this bad policy. And in your own practices, you have that, right? Whether you're OBGYN, whether you're family practice, pediatrics, orthopedics, ophthalmology, doesn't matter what it is, you also have those issues. How do I get someone to get the care they need because I have to jump through all these hoops? So at the end of the day, the important thing is the provider and the patient, right? We as providers want our patients to get care, and we want it to be done in a timely fashion, and patients just want to get better. You know, it's really easy from a corporate level to sort of lose sight of that. You can get sucked into the corporate mindset of just numbers, right? You're a number, you're an NPI, you're a TIN, you're whatever you are, but behind that is actually a real person, a real physician who's passionate about what they're trying to do, and to be able to have a great work life where they can offer the kinds of care that they want to their patients.
I'd like to ask Dr. Utecht if you could, Mike, share an example of how that process has worked to mold and shape a medical policy for the health plan into something that is more in keeping with the needs of patients in North Carolina.
Yeah, one thing we do is, obviously we have to go through clinical policies, and I mean, to be honest, we probably have about 240 clinical policies. There's a bunch, and we have to review these all the time, every month. And when we review these policies, they either come from the state or they come from corporate, and so they've all been vetted, you know, somewhere before we see them. Like experts in the field have vetted these policies, but we still go through. I read every line of these policies, and we had a particular policy. It was around sleep studies, right? And I'm an emergency medicine doctor. I'm not a sleep study expert. And this is what we do when we see policies that we feel need external review. We send them out to our provider network, and they'll look at these policies and weigh in. I reached out to one of our colleagues in the community, an ENT doctor who worked with pediatric patients, and had them review the policy. And she replied back to us and said, well, you know, what I'm noticing in our practice is that you're requiring prior authorization for children under 18 to get a facility-based sleep study. And we're like, oh, we are. And we said, well, you understand that children, by definition, cannot have a home sleep study. They have to have a facility-based sleep study. I'm like, oh, okay. So she said, why do you have prior auth on facility-based sleep studies for kids under 18? And I said, that's a great point. So we bought it back, and we bought it back to our medical affairs committee, and we removed prior authorization for kids. So now kids under 18-year-olds do not require any prior authorization for sleep studies. And this is just one example. I mean, there are lots of examples of policies where our physicians have weighed in and said, well, this is the way it's done, or this is the way it's moving. And what I love is the fact that we have made changes, what we call North Carolina specific policies, where we've made changes, and then when the next round comes where corporate has reviewed, or is coming back to review policies, they are now bringing their policies up to our policy. Like, they are now coming in line with us. And I think that's really powerful to show how effective that kind of relationship is with our provider community.
I think it's important to view the path forward in this enterprise with our partners as a learning opportunity. We've learned a lot. We are changing and growing. There is more for us to learn, and I'm very excited and happy to be part of that. And we all are looking for improvement and the betterment of the people who are enrolled in this health plan, and making sure that all of the doctors and others who are taking care of those patients have a place to call home at Carolina Complete Health Network, so they can solve problems and thrive in this environment.
Medicaid is, you know, it's not sexy, right? The state gave it up years ago because it was sort of distressed property, and they say whoever wants to buy the distressed property, we'll let you do that. So we are trying to help the most vulnerable people in an area that doesn't get a lot of public attention in terms of, wow, that's so sexy and good and looks great and look how popular. This is something that I think that the people in our company, whoever it is, whether it's our provider engagement, physician engagement, provider relations teams, whoever it is, that these people are really bought into wanting to do the thing that's right for for the patients, for the people that are members of our health plan. And they just really believe in that, even though there's not a lot of congratulations at the end of the day, because it's just not. There's no attaboys. It's just, that's what we're here to do, and that's what we do. And one last thing I'm going to say is that I think the one thing that shows the success we've had in doing this and the success of this model, because no one's done it anywhere before. And I think the success is in the fact that we are merging, that it's going to be a provider-led entity statewide.
Yeah.
And if that model was not working, this would not have been adopted. So everyone, corporate-wise, statewide, they realize that this new model is the way to go. And it is effective, and it provides a level of care and a level of service not seen before in the healthcare arena. So we're very proud of that.
I believe that we will be coming back to you in the future soon with additional information about some aspects of this plan that present opportunities for the physician community.